Thank you for joining us for ASPPH Presents webinar, sponsored by the Big Cities Health Coalition, for an introduction to the new Big Cities Health Inventory data platform. This platform, a resource to the public health research community, is a compendium of more than 12,000 data points comprising more than 30 health indicators. This webinar is part of the 2016 ASPPH Presents monthly series, which has been designed as a service to CEPH-accredited ASPPH member schools and programs of public health. A few housekeeping items of note. While you are in listen-only mode and your lines have been muted, we encourage you to ask questions throughout the presentation by using the chat or question box. We will address your questions at the end of the presentation. This webinar is being recorded and it will be available on the ASPPH website in the archived webinar section soon. Additionally, this webinar has been approved for 1 hour of CPH continuing education credit. Our speakers today are Chrissy Giuliano, the director of the Big Cities Health Coalition at NACCHO, who leads the group's strategic vision, oversaw the creation of the Big Cities Health Inventory data platform, and served as the primary author of the accompanying analysis. She holds a Master's of Public Policy from the University of Chicago's Harris School. Matt Holler is the account leader behind Socata's initiatives on behalf of high-profile public sector health organizations. Matt focuses on data sharing, data analytics, visualization, and empowering organizations to get more value from their data. Matt holds an MBA from Ashford University and a master's certificate in IT management from Villanova. Mark Silverberg is the technical leader behind Socata's initiatives on behalf of high-profile public sector organizations such as the Centers for Medicare and Medicaid Services, Centers for Disease Control, and many other clients to help them manage, share, and explain their data more effectively. Mark is an expert on cross-organizational data sharing, data analytics, and visualization. He also brings deep experience using data visualizations to help non-data savvy users understand data. And he trains clients, developers, and data scientists on how to use APIs and web visualization frameworks together. Mark holds a Master's of Science in Information Science from the George Washington University School of Business. Thank you for being here today, Chrissy, Matt, and Mark.
Thanks so much, Sarah, and thanks to the Schools of Public Health, Schools and Programs of Public Health, for partnering with us on this webinar. We're excited to share this with you. So we wanted to start with some learning objectives. So generally, we'll find out how to access key public health data points for up to 28 of the largest, most urban cities in the U.S. across these 9 categories of indicators that you see on the screen. We'll talk about how to compare data across cities, including how to create infographics and the like. So first, real quick, the Big Cities Health Coalition has 28 member cities. It is the forum for leaders of America's largest metropolitan health departments in the country's most urban areas. So to be part of our coalition, you need to be both large and urban. Right now, we represent, our 28 cities represent 54 million Americans, or about 1 in 6 Americans. And you can see the cities on the slide there. The coalition was founded about a dozen years ago when Tom Frieden, who's now at CDC, and Jonathan Fielding, when Tom Frieden was in New York City as the health director there, and Jonathan Fielding was the director in LA, they found the coalition to really look for a peer network. And a handful of years ago, it was brought here to NACCHO so that there would be additional staff support. So our partners on the Big City Health Inventory is Socata, and you'll hear from Matt and Mark in a little bit. They were our data partner and vendor on this work. This work was primarily funded by CDC, and the coalition as a whole is funded by the de Beaumont Foundation and the Robert Wood Johnson Foundation. So the Big Cities Health Inventory, currently online, it includes data from 27 cities. It will soon be all 28 of our cities. We're waiting on one more who joined us after this project had started. There are more than 30 health indicators that are part of those 9 categories we looked at before, including demographics. There was a report that was the 6th edition of this work, the Big Cities Health Inventory, that we released in November. It's currently being revised and repackaged a bit, so it's not on the website. but there were like 5 previous reports, and the last one was published in 2007, and that was not done by the coalition. So that newer version will be up probably in the next month on our website. So why the Big Cities Health Inventory is unique? We see it as a real snapshot of the health of people living in these dense urban areas with data primarily at the city level. There are a handful of our members that were only able to procure county level data, and those are noted in the platform, but the goal was really to capture that city piece. There are very few, and we don't really know of any one single data source that would allow big city health departments to compare health indicators across jurisdictions and what we like to think of as peer jurisdictions. So, for example, the county health rankings do exist, but those look at counties within a state in many cases, and this allows cities with similar populations and things like that to compare notes. The platform and the report also highlight CDC's Winnable battles and the Healthy People 2020 indicators and the innovation that's occurring in our cities. So urban centers really are the innovators of today. They often have freedom to try new things, whether that's because of political realities, or they're a little bit more nimble than state level or particularly federal level. And 83% of Americans live in metropolitan areas. Again, despite this, capturing city level data remains a challenge. So for the most part, the data that are on this platform were collected directly from the cities. We did do some work on the demographics and did fill in with some publicly available data as needed, but again, most of it came directly from the cities. So phase 1, which is what's up there on the data platform now, is mostly mortality or death rates. These are the data that were most easily collected and comparable across cities. Phase 2, which I'll talk a little bit more about later, aims to include indicators that give you a little bit more holistic picture of the community's health. So unemployment rates, potentially age of housing stock, things like that. So winnable battles, CDC has several, the list is about 20 or so. We focused in on a few of them. So there's tobacco, food safety, HIV, AIDS, community violence, and physical activity, obesity, and nutrition. And one of the key takeaways from collecting these data is that when you look at the Healthy People 2020 goals, which were created 30 years ago by HHS to provide 10-year targets to improve the health of all Americans. So when you look at the Healthy People 2020 goals and CDC's 2015 Winnable battle benchmarks, many of these cities have met those or are on track to meet them. I should say here before we talk about this that most of these data are 2012 or 2013, so there is a lag. So on this screen is this graphic that we made from the data platform for National Public Health Week. So you'll see that we include here binge drinking among adults, homicide, and obesity among adults. And so for binge drinking, 14 of the 19 cities that were able to report those data between 2010 and 2014 have hit that Healthy People 2020 target. And I should also note that we counted a city as meeting it if it met that target in any one of the years that were reported to us. You can imagine different cities reported different years. So to be as comparable as possible, we took any one of those years. So homicide, 10 of the 23 cities reporting data have already hit the Healthy People 2020 target, and obesity in particular, 17 of those 21 have hit it. And just a few similar stats up here. We looked at cancer and HIV, and about half of the cities have met their targets. All of the Healthy People 2020 target rather, all of them have met the target for diabetes. And they've also seen a great deal of success with adolescent smoking. All of the cities that were able to report data met both the 2015 Winnable Battle target and the 2020 Healthy People target. And then among adults for smoking, a total of 13 hit the Winnable Battle target of 17%, and then 4 of those 13 hit that Healthy People 2020 target. So these are some of the comparisons we're trying to make across cities at sort of a high level. So one of the things we also did in the report, and these are all online, is we had about a dozen case studies, and we wanted to not just present numbers of things in these cities, but also talk about where the cities had seen successes, what programs they had done, and sort of what was going on, to give a little context to those numbers. So one of the case studies looks at Healthy Philadelphia, and again, you can read the whole thing online, but basically they saw between 2006, 2007, and 2012, 2013, a huge drop in intake of teenager soda, more than 11% drop in obesity rates among African American boys, and more than 18% drop in obesity rates among Asian boys. As you can see on the slide, nationally there was no drop in rates in those same populations. So this was a real accomplishment for Philadelphia. And I should also just add that those data are slightly different than what's in the platform. In the data platform, we used YRBS so that it was comparable across cities. Those more specific numbers actually came from measurements that were taken in the schools. So another case study, we looked at 2 cities that worked on tobacco and were real leaders on tobacco regulations. So New York City has a tobacco 21 and minimum price laws. So those raise the age of sale from 18 to 21, and also set a minimum price of $10.50 per pack. There's also a story about Seattle regulating their e-cigarettes, and they were one of the first, if not the first, to prohibit sale of e-cigarettes to those under 18 and to ban the use of e-cigarettes in public places. For those of you who are local here in DC, just a heads up, the coalition is partnering with the Campaign for Tobacco-Free Kids and Trinity Health to hold a Hill briefing next week to talk about Tobacco 21 and raising the sale age, and that information can be found on our website as well. So the last case study that I want to talk about here is San Francisco and getting to zero. And so their goal was to lower HIV and AIDS deaths to zero. So they worked in consortium with a number of organizations, and over the course of some time, they doubled the number of HIV tests. They halved the number of HIV diagnoses between 2002 and 2013. They used pre-exposure prophylaxis, or PrEP, and also rapid ART, antiretroviral therapy, and made sure that people who were being treated for HIV or AIDS had continual access to care so that they could, continue to get healthier or stay healthy. So again, there's much more detail on our website about these case studies and the additional ones. So I'm about to turn it over to Matt Haller from Socata, but on this slide you'll see that is the direct link to the data platform. You can also link to it from the Big Cities website. As Sarah said, we have more than 12,000 points of data, which we say a lot because we're really proud of that, and they're all publicly available. So with that, I'll hand it off to Matt to go from there.
Thanks, Chrissy. And Socata has been engaged with Big Cities Health to create a data portal that, as Chrissy had mentioned, provides over 12,000 data points across 27 cities. The platform allows anyone to take advantage of the data that is traditionally locked away in PDFs and explore and interact with it all from their web browser. With BCHC, we focused on making sure that users of different backgrounds and technical abilities can make use of that data. Equally as important, the platform allows anyone to fully export the data as a snapshot, as well as build third-party applications using the APIs. I'd like to turn things over now to Mark Silverberg, a data solutions architect for Socata, who will walk us through the platform and share how you can make the most use of the data BCHC has unlocked as part of this initiative. Mark?
Thanks, Matt and Chrissy. So, hey everyone. My name is Mark Zuckerberg, as mentioned, and I want to just talk about how we've used technology to really make sure that all the really hard work that Chrissy and the whole team and the funders and Big Cities Health Coalition in general have put out and gotten from the members, and how all of that data can be made and can be used by lots of different audiences. So we're going to go through a few different sort of use cases and different interfaces that we're providing for everyone from people who might just be sort of, use a web browser and don't really want to create a custom visualization and just want to get numbers that they can report in maybe an article, etc., to people who want to create custom visualizations and make an infographic-y type chart and then maybe embed that on their website or a news article or print in their paper. And then also finally sort of get to the more technical class of users who might want to create a very custom visualization or bring this data into maybe an EMR or some other repository of data to make use of it, do correlations, things like that. So here on the screen we see bchi.bigcitieshealth.org. Again, you can get to this from bigcitieshealth.org. And the homepage is really just made to make sure that we get people to the right place. So you can click on the different links at the top to find the full report, to explore the data, which of course we're going to dig in mostly here today, as well as read some feature stories and see some other statistics about how much data across what categories and how many different places the data has been collected from. And so most relevant to this call at least, on the home page you can find the Explore the Data section, and you'll see two different drop downs to basically explore the data by city or by indicator category. So as Chrissy mentioned, dozens of different indicator categories from tobacco and cancer to demographics, HIV, etc., as well as more than 20, or I think 27, soon to be 28 cities and places that we've collected data from. And so these drop downs will help get you to a page that will more or less give you everything you need to know about the city or the indicator category that you chose. So I'm going to walk you through some of those views right now and sort of progress from what I would say sort of less technical, just get the data and go and use it in your report type users, to a little bit more of a data analyst, visualizer in the web browser, and then again finally to sort of a sophisticated data visualizer or sort of developer. So on this page, and this is just a screenshot of the website, you can of course go and look at any of the 27 cities that have been that we've collected data from. But so this is a page that gives you really all the health inventory information that you might want to know about for Kansas City, Missouri. And so we see that there's a table with the indicator category, in this case cancer is the first one, all of the different indicators, so there's many indicators per category, and then we have it in sort of typical pivot table or epi table fashion. You can see the different breakouts by race and ethnicity, gender, and then of course by year over at the top. And so it's important to note as we dig in further to the data that this isn't actually how the data is stored. This is just one way that we're representing the data, as sort of a lot of people would expect it in an academic journal or again in an epi table, etc. And so here we're sort of dogfooding and using the APIs that I'm going to talk about in a little bit to present the data in this way. But of course, if someone wanted to come along and create a chart that had trend lines or something else, or color these things differently, that's definitely possible, and we'd be excited to see and collaborate on that. And of course, this table can, you can copy and paste and print this and things like that. Similarly, for let's say you want to know everything there is to know or see all the different data points about tobacco as opposed to, or about an indicator category as opposed to a specific city, you can similarly choose on the home page to explore an indicator category. And from this view, we'll see all of the different data points from all the different places, the different indicators, the different race ethnicities, as well as genders about tobacco. And so in this case, the first indicator we see is percent of adults who currently smoke, and we see the data broken up by race ethnicity, gender, place, and year again. And I think this is sort of a good place to see that there, you know, as Chrissy mentioned, there really hasn't, other than the Big Cities Health inventory, there isn't a good forum for collecting and comparing city-level data. And so as we see, there are some blanks, and that it really just highlights some of the challenges that have been had in collecting data and getting consistent data to really try to compare as close as possible apples to apples numbers. And so it's definitely a challenge and something I think that we're able to convey, but also we've definitely moved the needle forward in this project. So these were views that are sort of already created for you. They're pretty simple, typical tables you might see, again, across the internet about different indicators, et cetera. What we wanted to really give people the power, if they had the time and interest in doing, is to build upon this information and not have it just be locked up in even web pages or PDFs. And so with our technology platform, what we're able to do is be able to show all 12,000 of these data points. They're all available to be taken down, manipulated in any sort of other external program, et cetera. And so this view might look a little busy, but it's really sort of, it's kind of what you can think of it as Excel sort of in the cloud or in your web browser. And so there's a lot of different functionality here. I think of it as sort of a Swiss Army knife for data, but the key gist here is that you can literally scroll down left and right, see exactly all the open access data that Christy and her team have put out there, and really take what you need, filter it, visualize it, et cetera, take what you need for your analysis. And so I'm gonna walk through a few of the different screens and views of how you might do that. So again, this can actually be accessed from the home page by clicking on Explore the Data and then clicking on the fact that you want to see the whole Big Cities health data inventory. So from this page, sort of there's different tools up here at the top. The first thing we might want to do if we want to create a visualization maybe about tobacco data is we would want to filter the data. So yeah, so here what I did was I clicked on filter, and then you can actually use these sort of, if you're familiar with Excel or other tools, it's pretty similar. You can actually filter the data to find exactly what you would like to see. So in this case, we're looking at percent of high school students who currently smoke. We're actually only interested in looking at data across all race, ethnicities, and both genders. So we sort of look at only part of the data. And then in this case, I wanted to just show that we might be interested in just a few different places. In this case, I'm here based in DC, and I wanted to sort of see how DC compares more or less to peers in the Northeast corridor. And so what I did was I filtered for just Washington, DC, New York, Philly, Boston, and Baltimore. And so what we've done here is we've taken those 12,000 data points, which was pretty overwhelming. It was a lot of data about a lot of different things across the whole U.S., and we filtered it down to all of the data points that we have for tobacco. And so again, we see here that interestingly, there's really only data from these 5 cities for 2013 and 2011. And so it will need to be careful to visualize this correctly so we're not comparing maybe 2011 data to 2013 and things like that. So I'm going to sort of move on to visualizing the data. And so after we filtered it, we can visualize it. There we go. And so again, this is the same filtered view of the data. What I just did was click on visualize and selected a few things such as the label, which would basically be the x-axis. So here we have the cities, and then I chose that the value, or for the value data, I wanted the column called value. Sometimes it's a percent, sometimes it is a rate per 100,000. So it's important to look at some of the metadata, which is in the table under BCHC requested methodology and other notes and such. And so then we also want to group by year so that we have 2 different columns, one for each year, so for 2011 and 2013. And so one thing I just want to point out here is that we see that Baltimore, we have sort of this slash line. I think this is important to note that the system sort of recognizes when there's data in the filtered view that one facet, in this case Baltimore, did not have data for 2011. So it's important to just note, and we sort of visually show you that by having these slashed lines. And so this is just a really simple visualization. Once you get the hang of it, it literally takes a few minutes, and I'm going to show you a few visualizations that the BCHC team has actually created that you can sort of take and embed and do things with very shortly. So before we do that, here's just a few other pieces of functionality, so sort of some screenshots of those other tabs in the top right, just to show some of the other functionalities available here. Really important to everyone on this team is making sure that all of the hard work that was put into getting the data, I'm sure, from all of the different partners, as well as some of the data came from CDC, sort of national level data, et cetera, for averages. We really want to make sure that it's extremely easy for everyone to get access to it. So we have a lot of different download options for you to choose from. I would sort of guess that most people are interested in getting just a CSV or an Excel file, but to support developers and others, we allow access in many other formats, including JSON and XML and other formats as well. Similarly, if you want to embed this, for example, what BCHC has done with some of their infographics on their blog, you can actually take a visualization that you've created, save it into your account, and embed it onto a blog. And so this is a way to interactively let people explore some of your analysis that you've done on the platform. And lastly, you don't have to do all the work yourself. BCHC has already created a lot of interesting visualizations with catchy names like what will kill you in Chicago and city comparisons of different diseases, have done some matchups of different cities. And so I'm just going to show a few of those outputs just to show the breadth of different data sets that or different visualizations you can create. Again, all from your browser, all for free, and you can save, you can print, you can share all of these. So here's an example of a visualization, pretty simple, of just looking at the E. coli rate, I believe, by city. And so we could have colored these differently. We could have included some more things, but this is just a really simple visualization that if maybe you're really interested in E. coli, or that you want to embed this, or that your constituents or your stakeholders might be really interested in this, you can literally just go over, click on embed, copy the code, put it onto your blog, and allow people to look at this. It will always link back to bchI.bigcitieshealth.org so people can come and see the provenance of the data. And most importantly, perhaps, as the team continues to add data for more cities, for more years, for more indicators, your visualizations based on their filters will auto-update. And so you will see, or your users and whoever is looking at your embeds will always see the latest data. Okay, just a few other examples of visualizations. Again, just to show sort of some of the things that are already there for you to look at. And then also, again, these are all created not by super technical geeks like me, but by just like normal people, students, PR folks, etc., of the data that is available. So here is another one. As you see that there's some additional sort of more advanced functionality if you look through all of the options under the Visualize tab to add things like an average line, or for example, the Healthy People 2020 goal to show what cities are there. And again, you can see where there is missing data, which is unfortunately a big reality, especially in health data. This is just one more thing. Again, just showing how you can compare cities. Of course, you'll need to think about the different demographics and other things of that city. So it's not exactly one city is better or worse off than the other. It's really just the data is the data. But you can include the numbers and just a lot of different functionality here for you to work with. So again, all of the stuff I showed you so far was sort of there to really make it easy for more or less anyone to do it. Of course, you need to sort of understand the data a little bit and look at the data, but we also are making available, and pretty important, is APIs, or application programming interfaces. And so Basically, what that means is it makes it really easy for developers to create more custom visualizations, things that you're sort of used to seeing in like the New York Times and Washington Post and Vox.com, maybe even BuzzFeed, and really create engaging, really custom visualizations that will always be kept up to date as the BCHC initiative puts more data on here. And so just to talk geek really quickly, you know, the API that's available, which looks like this, is the documentation. It's very extremely well documented. It's a RESTful API that speaks JSON, CSV, XML, and RDF. And so we're really excited to have people use this. There's a lot of different libraries that you can use with this API. Here are some examples of things not done specifically with this data set, but these are all different visualizations and sort of analyses that either I or other folks on the team, or actually members of the Socata developer community, have created. So, and there's code examples for all of these things. So for example, this one in the top left is actually predicting crime data in Austin, Texas. So they have a, you know, somewhat similar data set in a similar format, where they have different crime statistics. You can actually use this example as an R statistical package for Mac, Linux, and Windows to actually predict crime, and you can do, of course, seasonal trend analysis and other things. Here in the foreground and also on the left side is some BRFSS data from CDC, and we're just doing some, it's actually in SAS, obviously very popular statistical program, mostly for Windows and Linux, but we're able to take a look at different outliers and see using box and whisker plots or box plots where outliers might be, and might want to dig into that. Two more I just want to sort of call out, and again, there's free code out there to see how you use this API with these different external tools. This is in the background over here. We have New York City vehicle collisions and deaths per day, and so the purple line is different collisions, and then the orange dots are actually deaths caused by motor vehicles. And so this might be helpful in looking at different trends and causations. And lastly, maybe a little bit of a more sort of funny one is, you know, this is a heat map by day of the week and by month of party disturbance calls in LA. So LA publishes lots of 311 calls and customer service requests, and so as we might expect, you know, there's a lot more party disturbance calls on the weekend as well as Fridays, but then of course perhaps as we look during holidays, there are also a bit hotspots. So these are just a few things that can be done a little bit more advanced than sort of what you can do in the browser, but what we're really trying to do is make it really easy for, no matter what your technical or data literacy ability is, to be able to access all of this great data and make use of it in novel and interesting ways. So I'm going to pass it back to Chrissy, and thank you very much.
Thanks, Mark. Oops, went too far. I just one comment on one of the things Mark said. While the visualizations and things that are online update as new data are uploaded, if you download the entire data set and you're working with that offline, obviously, you know, you won't get those updated data. We are fairly regularly adding additional cities and additional indicators. We're working on bringing those cities online who are not able to secure all of the indicators. So I would just recommend to either check back online to see if maybe there are additional indicators, or my contact info is at the end of the slide set here. Just send us a note and say, hey, I'm looking to work with your homicide rate. I noticed 5 cities aren't there, you know, sort of what's the status, or something like that, and we can update you on that so that you have the most up-to-date information and potentially the most up-to-date data. So just to wrap up a little bit here, you know, there's the saying, what gets measured gets done. And we really have, as we've all said more than once, a challenge with these city level data. And we really need to look at increasing local health department capacity and health IT. And that, so a handful of our recommendations was that we really need to target resources, both dollars and people, at building infrastructure in terms of both data collection and analysis. So data collection is expensive. Hiring people is expensive, but also finding the people with the right skill set to do those analyses in health departments at city levels is really important as well. Obviously, everyone is interested in moving toward data that can be used to target interventions at not just the city, but the neighborhood and block level. And, you know, I would say that our cities are all over the map on those abilities. Some cities are really able to do that block level census tract neighborhood analysis, some aren't. So we're really interested in figuring out sort of collectively as a field, how can we push the ball down the field, as it were. And finally, you know, focusing in on really a handful of key health indicators that can have consensus definitions to allow for easier comparability across jurisdictions. So I'll give you an example from the current data that are up there now. So opioid-related mortality rates. The coalition has done work on opioids for the last several years. Obviously, it's also been an important topic nationwide. So a year ago when we were pulling these data together, we really wanted to include this important statistic. We found that I think of the 20 cities that were able to give us data, everybody collected it a little bit differently. Everybody had a different source. Some were able to do age-adjusted, which is, if you don't know, the standard for mortality rates. Others were not able to do it age-adjusted. So we went to our members and we said, look, we all know this is important. These data aren't comparable. What do you want us to do? And we decided that because it was so important and such an important issue, that we would put those data up there. And we actually have, if you play around with the platform, we have 2 different indicators, really. We have opioid-related mortality rate, age-adjusted and crude. And even within those 2, not everything is absolutely comparable, and we have that footnote. As a side note, we are working to bring those definitions together and to have one indicator that we can compare across the cities, but there are some other indicators similar to that where we'd really like to have greater comparability. So on that note, watch this space. We will be updating the data platform. Version 2.0 will be coming by the summer, and that will include some of those additional indicators that I talked about at the beginning, as well as some design changes to make it a little more visual rather than tables of numbers. And also we hope to increase the number of cities that have all the current indicators that are in there. So I think that's my contact info and the coalition's contact info. And with that, I will turn it back to Sarah.
Great. Thank you so much, Chrissy, Matt, and Mark. We will now take this time to address questions from the question box. Please feel free to type your questions in the question box now. All right, let's see here. The first question, what data will be added in version 2.0 of the data platform?
Thanks, Sarah. So this is Chrissy. I can answer that. As I mentioned, we are looking at the possibility of indicators that present a more holistic view of the community, those that aren't just death rates, but also look at potentially disease burden. Now I will say that I am not optimistic that we're actually going to get to disease burden in this version of the indicator, but some examples of indicators that we're hoping to add, and these are from publicly available sources, mostly census data. We'll be looking at preschool enrollment, cost of housing, uninsured rates. We're going to add to the demographics and include language spoken at home. I think I mentioned unemployment rate. We're also going to look at violent crime from a national, the reported violent incidents database. And so we'll be definitely, or most definitely, including those. And then we're also going to work with the cities to see if we can get some emergency department visit related data, as well as some blood lead level information in children under 6. You know, again, not everybody can do this, and at this point, and not everybody can do it in a way that is comparable, but we're going to try, in addition to what I mentioned, the opioid related mortality, and in making that definition more comparable. And the plan is to continue to add indicators, you know, as things become available in publicly available data sets at the city level, or as our cities say, hey, can we do X? This would be really important for us to share.
Wow, thank you. A lot to come. The first presenter mentioned that there are, the next question, sorry. The first presenter mentioned that there are 20 or so winnable battles, but 6 or so were selected for this project. Is this correct? And if so, what criteria or processes were used to select the subset of winnable battles?
Yeah, so that was basically based on what data were easily collectible at the city level. You know, we had to go from the 20 or so to, you know, 5 or 6, and we wanted to cover those where we thought we had data. And, you know, there was a little bit of weighing issues that were important to folks in the coalition.
Great, thank you. The next question, I'm particularly interested in using these data to teach students how to do statistical analysis in a program like STATA or SAS. One important aspect for such a project is having data points from individual people, not just group summaries, so that we can calculate things like standard deviations or 95% confidence intervals. We would also need info not only on health outcome, race, gender, and place, but also various other confounders such as SES and age that students could choose to correct for. Is this kind of individual level data available, and what sorts of variables are available for each individual?
We do not have individual data available. I would guess that we would never have that level of data available. You know, it will really be snapshots at the city level. Now that could change in 10 years, but you know, it's not in the immediate plan of things to figure out. Now I will say that one of the things folks are interested in having us add are the confidence intervals for the data we have there now, and we're working on that. We need to work that into the design and then also gather that information because not all the cities provided it originally.
Yeah, and this is Mark. I would just add that, you know, while it's a little bit, you know, again, as Chrissy said, outside of maybe the scope of BCHC, I mean, if in case you're not aware, of course, CDC is one of the major funders and supporters of this coalition, and so they have other systems called, sort of by the National Center for Health Statistics, called Vital Stats and other things that do have some more sort of raw individual level data. We can definitely talk more about things like that if through Chrissy. I'm sure we can get connected if you want a little more details.
Mm-hmm.
Great, thank you. And along that same line, how are cities defined, especially when using data sources that typically do not sample at that level, such as BRFSS?
So for the most part, that's a great question and has kind of been our nightmare for the past 18 months. So for the most part, the city was defined along, I hate saying city to define city, but along sort of the traditional city line, right? So for example, Phoenix Maricopa County is the member of the Big Cities Health Coalition because Phoenix is served by the Maricopa County Health Department. However, in previous versions of this report, the data were reported at the city level for Phoenix. So to follow that, we used Phoenix this time. So that mostly fell to the city epidemiologist to work with us, you know, to define what that meant. And, you know, the folks in the cities know what that means. So they reported to us, for example, Phoenix level data. With YRBS and some of the BRFSS data, it was, you know, CDC's definitions. However, they define that, you know, a lot of the YRBS is done through the urban school districts. So It's not 100% apples to apples. I like to think it's better than apples to oranges, but that's one of the things we're working on, you know, as we continue to build this out. We really struggled with making sure we had the data that everybody wanted to see from as many cities as possible that were as comparable as possible. And I tell you, we spent a lot of time talking to people about you know, can we say this? Is this okay? Is this close enough? And at the end, we wound up taking out some data. So one last example, so in the slides I showed, those numbers, the obesity numbers for Philadelphia, Philadelphia had previously given us those numbers to report in the platform because it's their best measure. It comes directly from the school district, the health department collects it, so on and so forth. The vast majority of obesity numbers we got from the other cities were YRBS. And we didn't want to have these numbers that were collected in a different way in a different population stand up against you know, the majority of other cities that had the YRBS. Similarly, California collects data in a way that is different enough from the YRBS that for some of the cities we also kept out those obesity rates. So it was a challenge. For the most part, we erred on that side of being conservative about what was included for those comparability purposes.
Wow, great, thank you. You said that you're trying to get as many cities as possible and you have almost 28 loaded. Is there a goal number of cities to be participating in this?
Yes, sorry, I should have been clear about that. So right now it is the Big Cities Health Coalition members, member cities. And so we have 28 member cities. When we started this project, we only had 20 members in the coalition. So we started with those 20. Several of the cities that joined about a year ago were able to fairly quickly get us those data. So they were included in the version that went live late last year. There was one that just gave us data and another that's working on it. So by June, we'll have all 28 of our 28 Big Cities Health Coalition members.
Great. You mentioned that health departments need staff who can analyze the data. What skill sets are needed, and related to that, are city health departments hiring at the level needed to meet this need? Are you aware?
Yeah, so I don't want to speak for them, and I don't want to have too many sweeping generalizations. What I can say is that even among our 28 cities that are, again, the most urban and, you know, the largest cities in the country, it varies immensely. It varies according to money that they have to spend on these things, and, you know, who they can hire and how many people they can hire and things like that. So, you know, it will come as a surprise to nobody that New York, Chicago, Boston, LA, they have you know, not to leave out my other 24 members, but, you know, they, for the most part, have really top-notch data collection and analysis, partially because they've made it a priority, and you know, several of them have the dollars to support that work. I don't want to go too far here, but I would assume that, you know, all of our cities would love to be at that same level and, you know, can work to get as many people in-house that can do this and do the analysis that they want and need as possible. Hopefully I didn't get myself in trouble there with my members.
I think that was a pretty safe answer.
Okay.
Are there
yeah, I'm putting the disclaimer on the record here.
Yes, yeah. Are there specific benefits to API integration with external analytical tools versus exporting the data and then uploading to another tool for manipulation?
Mark, yeah, that question has your name all over
it. No problem. That's a great question. And so I think it's sort of a continuum, and everything sort of has its own trade-offs. I would say, as Chrissy sort of mentioned and said it quite well, you know, if you just download the data and do your thing with it, whether it's, you know, a simple chart off the platform, you know, in SAS or Excel, Tableau, etc., you're not gonna have the benefits of all the updated data. And so this isn't just a one-time data dump. This is a continuous process, as Chrissy has mentioned in many different answers, of getting new data from new places, new different indicators, et cetera. There is sort of a middle ground, so to speak, feature on the platform where when you're on the data set, let me see if I can go back to that slide and actually show it visually. You can actually subscribe to email updates as the data set is updated. So, so that is sort of one thing. But really, as we said before, I think this is the button right here to get updates about the data set via email when it's updated. But really, if you use the platform, whether the tools or through the APIs, there's something called OData, which allows you to get data into Excel or Tableau or Power Query, which is a Microsoft product really easily. You'll have the continuous updates. Something just sort of food for thought is that often, you can be a little bit more nimble and efficient if you're using data that's already on your computer. So I might suggest maybe if you need, export the data, do your new novel analysis, interesting things, and then once you've sort of figured out exactly what you want, then hook it up to the API. And we're definitely here to help, and so you can contact Chrissy and she'll sort of route requests and for help as needed, but more than happy to sort of talk geek, help with code, or even just talk through some questions that you might want to ask and how best to get those answers from the data.
And, I would just add, thanks, Mark. I would just add that if you have a question about when data was last uploaded or when data is going to be uploaded, or, if things have changed, you should just feel free to email me and we can work through that.
Great, thank you. A lot of opportunities there. So I have a couple of kind of a two-part question. Have you looked at, or do you have plans to look at, policies or practices that have been implemented as a result of the data or are related to that data in some way? And follow up, how can schools and programs of public health work with these large city health departments to use the data to influence policy changes, inform and educate citizens, funders, and state health departments? It's kind of a lot of parts there.
Yeah, so let me take the second part first. The Big Cities Health Coalition is actually starting another project looking at workforce within our city health departments, and we'll be doing a survey with our health departments to identify needed skills and gaps around a number of capacities of master's level staff. So we anticipate over in the next year having a better answer to this question and being able to narrow it a little bit into, and here's actually what we know is missing or needed. But all that said, I would say there are, again, not sitting in a city health department, there are a number of things that schools and programs of public health can partner on with cities. And the vast majority of cities and health departments love free or inexpensive help. So I would say anybody sitting in a program or a school in any local health department area should reach out if there's interest or mutual interest. I would also say that anybody should feel free to reach out to me and my colleagues here, either specifically at the coalition, or we can connect you to other NACCHO folks to figure out how you also might make those connections. I do a lot of connecting folks to our health officers and other people in the health department, and I'm happy to do that. We have an intern who's a master's of public health student, so I think there's a lot of room for those partnerships, and once they start, they can go anywhere. So as far as policies, programs, best practices, we are hopeful that the third phase of this project will be funded by CDC starting in July to try and bring in some of that context, not just data. So we will in no way, shape, or form be doing any causation among, this city has X policy and that's why their whatever rate is better, but we will be bringing in to be defined a little bit more, again, either some practices or statute or programs that are going on in a handful of these areas that may affect the rates, but sort of the ideal would be a one-stop shop, if you will. So you go to a website and you see that Chicago has, you know, a certain rate in obesity. I'm making this up. Nobody in Chicago think I'm saying this as true, but, you know, has a certain rate of obesity in Chicago. And hey, look, they have these 3 great programs. Or really, you know, with Philly, we know that they made some great changes. So hey, how did that happen? You know, what are some of the things that were going on in the city at the same time? Again, whether it be a policy or a practice or a program.
Fantastic. Thank you so much. It looks like we have, you don't have any more questions coming in, so I just want to thank our speakers today, Chrissy, Matt, and Mark. This has been really informative. I'm sure you'll be getting a lot of follow-up questions. As a reminder, this webinar was recorded and will be made available on the ASPPH website in the archived webinar section soon. Following the end of this webinar, all attendees will receive an email from NACCHO's research team to the email that was used to register for the webinar, asking you to complete a very brief survey. We would greatly appreciate it if you responded to this survey, as your opinion is very important to us. Please be sure to contact ASPPH or the Big Cities Health Coalition with any additional questions, and also to register for the next webinars in the ASPPH Presents series. Lastly, the ASPPH, along with the Association of Collegiate Schools of Architecture, is co-sponsoring the 2016 Fall Building for Health and Wellbeing Structures City Systems Conference. Abstract submissions are invited from the ACSA and ASPPH communities, as well as non-member practitioners and faculty that address the range of topics related to built environment and human health. The topic areas and more information are available on the conference website. Thanks again. Have a great day.
Sarah, thank you so much.
Thank you.